arrhythmogenic right ventricular dysplasia and unclassified like a fibroelastosis and LV non-compaction. So we are going to discuss each and every cardiomyopathy one by one. So first of all, what is the etiology for the cardiomyopathy? It could be ischemic, valvular, hypertension, inflammatory, metabolic, inherited or toxic reaction, or peripartum. So what is dilated cardiomyopathy? Dilated cardiomyopathy is, that means anything which is dilated, right? With the cardiomyopathy is a contractile dysfunction. So impaired contraction of the ventricle. So reduced systolic function with or without heart failure. Doesn't mean that patient have a heart failure. It can be characterized by myocardial damage. There are multiple etiologies as we discussed already. There are majority of cases, you can say 90% are idiopathic. That means no known cause. Incidents are higher usually in mild and asymptomatic cases. For years, nobody knows that patient have a cardiomyopathy. When they come at the age of like 50s, suddenly they did echo and they found that they have a cardiomyopathy. So one by one we discuss, the most common is ischemic. That means you can have a myocardial infarction, stable angina, unstable angina. Could be cardiomyopathy, could be due to ischemia, it could be valvular. So mitral valve disease, it could be aortic valve disease, tricuspid or pulmonary valve disease. Hypertension, familial, idiopathic with unknown etiology. Can have infectious etiology, it could be viral infection. Most common viral, Coxsackie B, CMV, and parasitic infection. Those people who are living in tropical areas where the Chagas disease and toxoplasmosis is more common. Non-infectious etiology can be systemic lupus erythematosus, rheumatoid arthritis, peripartum. Toxic can have a drugs when you have a chemotherapy for any cancers like anthracycline, doxorubicin, and could be alcohol induced. Metabolic, if some patient have a like a hyperthyroidism or hypothyroidism, they can develop a cardiomyopathy, pheochromocytoma, diabetes, and acromegaly. Nutritional deficiency is also one of the cause for a dilated cardiomyopathy, like a thiamine is a basic, like a thiamine deficiency, very selenium, carnitine. Neuromuscular dystrophies like Duchenne is the most common. It's an X-linked disorder. Usually they can have a cardiomyopathy and usually a dilated cardiomyopathy. So viral myocarditis, in our scenario, we see lot of patient with the acute viral myocarditis. Last, I think 2 months back, there was a doctor from civil hospital. She just had a sore throat and she died with a viral myocarditis. It's a very dangerous disease. So if somebody have a Coxsackie B or normal flu infection, self-limited infection, usually in young people, but after that they develop a cardiomyopathy. Mechanism could be myocyte, cell death, fibrosis, immune-mediated injury, but there is no benefit with immunosuppressive drugs. Although there is a benefit with the immunoglobulin. Um, Alcohol cardiomyopathy is also we do see commonly these kind of patients. They are chronic users. They are usually reversible with the abstinence. If they quit the alcohol, they can have recovery in cardiomyopathy. What is the mechanism? It's also myocyte cell death, fibrosis. Basically, directly inhibit the mitochondrial oxidative phosphorylation and fatty acid oxidation. Okay, so familial cardiomyopathy. Sometimes you can see a 5 family member all have cardiomyopathies. So if one of the family member have a dilated cardiomyopathy, you screen all the family members with the transthoracic echo whether they have a cardiomyopathy or not. Sometimes this is a inheritance, autosomal dominant, recessive, or X-linked or mitochondrial diseases. They are associated with the familial cardiomyopathy. Associated abnormalities can be like a Duchenne, as I told you. There could be musculoskeletal abnormalities, neurological and auditory abnormalities. Mechanism, what is the mechanism? There is an abnormality in energy production, contractile force generation. There are specific genes, there are gene problem, genetic diseases like myosin. Somebody have a deficient myosin gene, actin or dystrophin. so they can have this dilated cardiomyopathy of familial origin. So the other most common we do see is we do a pregnancy heart diseases in this patient. Peripartum cardiomyopathy is the most common. Usually the last month of the pregnancy and 5 months post delivery. These patients present with a shortness of breath, heart failure. They are usually they don't diagnose very early because they usually present in the last month of the pregnancy with the shortness of breath. And this shortness of breath is very difficult to differentiate from the shortness of breath of the usually occur in the pregnancy. So they can have symptoms of heart failure. And when you do an echo, the ejection fraction is very low. Sometimes you can find it 20% a year with those kind of patients. So these are very sick patients. Never tell them to pregnant again. Okay. Because the higher chances of mortality, 44% women die if they pregnant again. Okay. So the dilated cardiomyopathy, you can see here this is an autopsy specimen. This is the dilated cardiomyopathy. How dilated is the ventricle? This is the right ventricle. This is the left ventricle. So this is a fibrosis, scarring, and this all whole dilated ventricle. So there could be a mechanism in the heart failure, how they got the cardiomyopathy. That could be ischemic, myocardial, or genetic basis. There could be neurohormones, cytokines, or oxidative stress. So they alter the molecular expression, changes in ultrastructure, myocyte hypertrophy, myocyte contractile dysfunction, apoptosis, fibroblast proliferation, collagen deposition, ventricular remodeling, hemodynamic derangement, and clinical overt heart failure, and patient can die with the arrhythmias. So what is the pathophysiology? Everybody heard about the initial compensation for impaired myocyte contractility. So when the actin and myosin, they bind together with the help of calcium, and then they contract. So Frank Estrella mechanism, I think everybody know about this, is the preload increases, the cardiac output increases. Up to the certain level, when the myocardial stretch is too much, that it doesn't contract very well, and the cardiac output slowly fall down. So your mechanism is going to fail. So the patient will develop heart failure. Neurohormonal activation, increase intravascular volumes, eventually decompensation. That means now there is no room for recovery. Ventricular remodeling, myocyte death, apoptosis, and the wall becomes regurgitated. So this is Frank Starling curve. When we increase the end diastolic fiber stretch, that means this is an end diastolic volume. When your preload is increased, when your preload is increased, when increased filling pressure from SVC to IVC, flow goes into the right ventricle, and eventually from pulmonary artery it goes to the left atrium and to the left ventricle. So it is the end diastolic volume before the LV contraction. So it increases as the volume increases. Your preload increase, it increase the stroke volume, it increase the LV work, increase the myocardial stretch, increase the myocardial fiber stretch. But it's a maximum strength if ventricle is at maximum level, it doesn't stretch anymore after that. And after that, ventricle start to fail, and LV contraction reduce, cardiac output reduce, and patient have heart failure. So these patients are clinically very bad prognosis. There are other different neurohormonal mechanism. Most common is Renin-Angiotensin-Aldosterone axis mechanism. For you guys, this is the most important. Majority of medication work on this system. So how it is going to work? Angiotensin is converted into angiotensin 1, and from angiotensin 1 it converted to 2. So we give ACE inhibitors. These medication affect on this pathway. From angiotensin 2, it converted into aldosterone. So we give spironolactone to block the production of aldosterone. We can also give angiotensin receptor blockers. It can block the angiotensin to to converting into aldosterone. So these are the things which can cause heart failure. Aldosterone, if you have excessive aldosterone, it can worsen your heart failure. So these are the medication which help in the heart failure. What are the effects of angiotensin 2? It causes a vasoconstriction, aldosterone production, myocyte hypertrophy, fibroblast proliferation, collagen deposition, apoptosis, prothrombotic, it's a pro-oxidant, causes endothelial dysfunction. What are the effects in kidney in heart failure? When you have a low cardiac output, so you have a low renal blood flow, low GFR, increased renin production, increased tubular absorption, increased free water retention. So eventually, ventricular remodeling in heart failure occur. So what are the types of ventricular extracellular stimuli for the myocyte hypertrophy? It could be mechanical, as I told you. If you stretch the fiber more and more by increasing preload, so it's a mechanical stretch. So you can have a vasoactive peptides, endothelium, norepinephrine, and you can have peptide growth factor, different cytokines. So these are all mechanism for the pathophysiological mechanism for the heart failure. Now, when you develop a biventricular congestive heart failure, you will have a low cardiac output, fatigue, lightheadedness, hypotension. You have a pulmonary congestion, dyspnea, orthopnea, and PND. Systemic congestion, you have edema, ascites, weight gain. So these are the symptoms. What is a physical examination? When you have a decreased cardiac output, tachycardia, decreased BP, decreased pulse pressure, you have cold extremities, pulses alternance, means one beat is strong, one beat is weaker. You have a pulmonary venous condition, that means you have heart failure, raised JVP, you have a crackles, you have a pleural effusion, and in cardiac you have a laterally displaced apex beat. S3 is when you have a increased filling, so you have a mitral regurgitation, murmur. Systemic venous condition, you have JVP, hepatosplenomegaly, ascites, peripheral edema. These are usually in advanced stages of heart failure. What are the line of investigation? You start with the chest X-ray. So chest X-ray, you have a enlarged cardiac slit, you have interstitial edema, you can have a pleural effusion. ECG can be normal, can have a tachycardia, can have a atrial fibrillation, can have a VT, can have a LVB. Every kind of ECG you can see when you are going to come in practice. Most important test is BNP. So when you have to rule out any kind of failure, so you do a BNP test. And other, if you rule out the connective tissue disorder, ANA, rheumatic, or thyroid function test, you do ferritin test, echo, and cardiac catheterization if you think of ischemia. And final test is endomyocardial biopsy. We rarely do for some rare disorders. So this is the echo in cardiomyopathy. This is the left ventricle, this is the left atrium, and right ventricle. You can see this is more or less very dilated ventricle. So this is most important for your level NYHA classification. So what is the NYHA 1, 2, 3, 4? We have 4 classification. When you ask the symptom from the patient, if patient says there is no limitation of physical activity. So in ordinary physical activity, if I'm working daily, I don't have any symptom, that means it's a class 1. Class 2 is a slight limitation of physical activity. Class 3 is a marked limitation of physical activity. If I'm like on second floor, I'm getting short of breath. So these are the symptoms of class 3 angina. Class 4, that means I'm short of breath at rest. I don't have to move at resting, shortness of breath. And these are the symptoms you have to ask from the patient, NYHA 1, 2, 3 when you are writing in a history. Okay. So what are the drugs we can use? As I told you before, you can reduce the preload by diuretics and immunodilator. You can give vasodilator, ACE inhibitor. If patient is acutely ill, so you give inotropic support. Chronically, if the chronic heart failure, they admitted recurrent and their mortality is higher usually. And then best treatment is heart transplantation, but we in Pakistan we don't do a heart transplantation. So there are, for your level, you should know what is the mechanism of uh, drugs. Nitroglycerin, we give nitroglycerin and long-acting nitrates. What is the, it directly acts via nitric oxide. So it's a veno and arterial dilator. So it's an anti-ischemic drug. So it helps vasodilatation of coronary arteries. Nitroprusside we don't use commonly. We use hydralazine in those patients who have deranged creatinine. So we give, it's a direct arterial dilator, and the long-term benefit with this drugs is not proven, but you can give if somebody have a renal dysfunction. ACE inhibitor usually you give as a veno and arterial dilator. It's a long-term medication. When once every treatment you have a chronic heart failure now, the risk of VT and arrhythmias are higher, then you put a cardiac resynchronization therapy. This is a device we put in the heart. It's a subcutaneous device. Then we put one lead into the LV, one lead into the coronary sinus and left atrium. So it prevents from sudden cardiac death, but it's very expensive. Risk of sudden cardiac death with the LV dysfunction is, if your EF is less than 35%, we recommend to put a CRTD. If there are some ECG changes, there are some criteria to put a CRTD. You refer to cardiologist at your level. It's not important to read everything, but when you come in final year, I will teach you what are those things. Anti-arrhythmic drugs you can give. So there are other cardiomyopathies, hypertensive cardiomyopathy, in which the myocardium is thickened, hypertrophied. So this is called a hypertrophic cardiomyopathy. So the more common hypertension in women, and usually if you can see the echo, always baseline of investigation, if patient is short of breath, you do a transthoracic echo. So this is the hypertrophy of the ventricle. So these patients have normal ejection fraction. They don't have problem in systolic function. They have problem in diastolic function. So their diastolic function, that means they have a diastolic heart failure, and this is a different entity we will discuss. And for this reference, we are only concentrating on systolic dysfunction. Diastolic dysfunction is a separate topic. So these patients have a, you always remember, heart failure with the normal ejection fraction is a diastolic dysfunction. So if somebody have a heart failure with the normal EF, this is the diastolic dysfunction. So hypertrophic cardiomyopathy is a different entity. It's a risk of sudden cardiac death, left ventricular, not due to pressure overload. This hypertrophy can be variable in location. It could be asymmetric, symmetric, apical. There are different types, reverse. There are vigorous systolic function. The function is very good, but they have impaired also diastolic function. So what is the diastolic function? Systolic function is the contraction. Diastolic function is for the relaxation, when the in the diastole ventricle start to relax. So there is impaired relaxation of the ventricle. So you have what? Elevated diastolic pressure. So the mortality is higher in these kind of patients, because this is, as the hypertrophy increases, the risk of sudden cardiac death is higher. Majority these hypertrophic cardiomyopathy, 55% are familial with the autosomal dominant transmission. There are different genes. They are not 4 genes. There are more than 4 genes. But most common is these beta MHC, cardiac troponin, protein binding C, and alpha tropomyosin. Reminder are spontaneous mutations. Some people doesn't know even what is the cause of hypertrophic cardiomyopathy. Some genetic study comes to be negative. So you for a hypertrophic cardiomyopathy, run in families, and they have risk of sudden cardiac death. This is like this patient doesn't have a history of hypertension, so you can rule out this is a hypertrophic cardiomyopathy. The ventricle is so thickened, so it doesn't have ventricle is so small after this thickened ventricle, so there is less cardiac output, and the patient can die with a low cardiac output state. So never dehydrate this kind of patient. Make sure they are always hydrated. They should not go in sun exposure or like heavy exercise. They cannot play a basketball. They can have a resting type of activities, like they can They can do a table tennis and these kind of things, but not a heavy workload exercise. You can see how thick is this ventricle. So even cavity is so smallish, and aorta have less space, so low cardiac output. So the contraction is very vigorous for these patients, but this is the risk of sudden cardiac death because of thickened intraventricular septum. So we do echo for those patients, baseline of investigation. There are different variants for this cardiomyopathy. As I told you, for your level, it's not very important to know everything about. When you come in final year, you will know the different things. The different symptom for this. So when you have a myocyte hypertrophy, so these can be LVH, left ventricular hypertrophy, causes impaired relaxation. So diastolic dysfunction can have increased pressure, filling pressure. This is called EDP. Patient can have a dyspnea. So increased myocardial oxygen demand. Sometimes they compress your coronary arteries, so can have angina. So because of ventricular arrhythmias, ventricle is so thickened, so they have a syncope and risk of sudden cardiac death and VT, and they have low cardiac output. Always remember to hydrate these kind of patients. This is the thickened ventricle. This is your left atrium, left ventricle. This is your aorta. When your ventricle is so thickened, it sucks your mitral wall anteriorly flat. So it causing a dynamic LVOT obstruction, right? So when you have a dynamic LVOT obstruction, may not be present at rest. When they are dehydrated, when they run, they can have this dynamic LVOT obstruction, and increase LVOT gradient, your increase heart rate, decrease preload, so can increase the LVOT gradient. So how do you increase the BP of this patient, increase the preload, hydrate them, so they can feel better. So if they have a syncope, or you have to be worried about these kind of patients. So always evaluate these patients. So the borders, the findings, they can have a crescendo, decrescendo, systolic ejection murmur, S4 gallop, and they have a pulses difference. That means they have a weak and a strong pulse. So there are some physical findings when you come into clinical rotation, how you differentiate from valvular AS. As I told you, preload, increased preload is better for these kind of patients. When you have Valsalva, when you from sitting and you go upward standing. So this is a kind of Valsalva you do. So your preload is decreased, your afterload is decreased. So your Hocum is increased. In AS murmur, your AS murmur will decrease, Hocum murmur will increase. When you squat, your preload will increase, means SVC IVC flow is more. You have more cardiac output. That means your preload is less now more. So you have less murmur for Hocum. So these are the findings you can differentiate. Standing will decrease the preload, also increase the Hocum murmur. So sometimes they can, when they have a dynamic LVOT obstruction, they can have a hollow systolic murmur secondary to mitral regurgitation. You can do a ECG for these patients, echo, and cardiac catheterization. What is the treatment for these kind of patients? Give beta blocker, but don't make them hypotensive. Make sure they are not hypotensive. Calcium channel blocker, you can give anti-arrhythmics, and you can put for prevention of sudden cardiac death, we have ICD devices. Antibiotic prophylaxis for infective endocarditis, there no therapy has been improved to improve the mortality. The surgical treatment, myomectomy, dual chamber pacemaker, or sometimes we do in we do ablation. Hypertrophic cardiomyopathy is the most common cause of death in young people. The magnitude of hypertrophy is directly correlated to the risk of sudden cardiac death. Young patients with an extreme hypertrophy and few or no symptom are substantial risk of sudden cardiac death. So prognosis, sudden cardiac death is the how you survive. You can put automated ICD devices for those kind of patients. How you predict this adverse prognosis, early age of diagnosis, familial form, history of syncope, ischemia, and ventricular arrhythmias on Holter. You can give a amiodarone for if they have arrhythmias. For your level, I think it's too high. When you go in final year, you will, when you come into contact with the patient, you will know what is these things. There are other athlete heart. How you differentiate from athlete heart? They have like endurance training. They are very like a marathon runner. They have same findings, but the septum is less than 13 millimeters. So this is like athlete heart. Other cardiomyopathy are restrictive cardiomyopathy. There's impaired filling due to stiff ventricles. That means your ventricle is so thickened and stiff, can have a improper filling. That means your ventricle is small cavity, filling is improper. So this is a restrictive cardiomyopathy. You have usually infiltrative diseases like idiopathic, it could be familial, hypertrophy, scleroderma, diabetes, infiltrative amyloidosis, sarcoidosis. There are different syndromes. You don't have to remember everything. Endomyocardial fibrosis. Okay, so what is the why amyloidosis? Usually, primary amyloidosis, immunoglobulin light chain in multiple myeloma, they deposit in the heart also. In secondary amyloidosis, deposition of protein rather than immunoglobulin, senile, familial, and chronic inflammatory. Restriction usually is replacement of normal myocardial contractile element by a infiltrative interstitial deposits. So as you can see, this is the thickened myocardium. It's a shiny myocardium. Usually we can see in echo. This is the shiny myocardium. It's a sign of restrictive cardiomyopathy or amyloidosis. So this is the shiny thickened myocardium in amyloidosis cardiomyopathy. Restriction affect usually they can have heart blocks, arrhythmia, and they can die of sudden cardiac death and the sarcoidosis. And endomyocardial fibrosis is like eosinophilic infiltration in the LV apex. It look like a thrombus. So usually thickening of usually apical obliteration or inferior wall are more involved. So when you do a urinary eosinophil, they are very high. This is the clinical finding. Right heart failure in restrictive cardiomyopathy is more common than the left heart failure. Usually dyspnea, orthopnea, peripheral edema, ascites, hepatomegaly, fatigue, exercise intolerance, and they can mimic with the constrictive pericarditis. This is in another talk, so I'm not going to go in this detail for your level. So 2D echo, cardiac, and endomyocardial biopsies for the diagnostic studies. Treatment, treat the underlying cause. If you have amyloidosis, multiple myeloma, treat separately for every disease. Give diuretic for the heart failure, digoxin. Avoid, usually we don't give digoxin in amyloidosis if you know the cause. And arrhythmia, usually the atrial fibrillation, you give amiodarone. Pacemaker for conduction abnormalities, and anticoagulation for thrombus if you have thrombus anywhere. So there is another cardiomyopathy, ARVD, we call arrhythmogenic right ventricular dysplasia. It's a myocardium of RV free wall is replaced by a fibrofatty tissue. Regional wall motion abnormality and function usually cause of sudden cardiac death in young people. So you can do an echo and cardiac MRI for RV dysplasia. LV non-compaction is usually prominent trabeculation, deep recesses in the LV apex. Thin myocardium during embryonic life, the compact and non-compact myocardium doesn't form properly. So they have a prominent deep trabeculation in the LV apex. If you can see here, this is a trabeculation here. There are deep recesses. You can see here also.